This conference will now be recorded.
Hi, everybody. It's John Antonucci. This is AnCan's prostate cancer discussion group for the high-risk metastatic and advanced prostate cancer people. It's February 25th, 2025. And we do want to thank our sponsors for helping keep us going. That's Bayer, J&J, Myriad, Telix, Blue Earth Diagnostics, Novartis, and I'm not quite sure of Foundation Medicine. Rick will correct me if they're still on or not on. Yes, they're still on. They don't require us to pitch their products, so you don't have to worry. We're going to, whatever experiences we share with you are going to be unbiased. We have a couple of new people tonight that I would like you to welcome. Hank and Matthew L. And then after we talk to Hank and Matthew, we're going to go down the list of people that have things that they'd like to bring up. I would also like to introduce everybody to Richard Wassersug, who is visiting us tonight. He's the author of a book on ADT and a major authority. So this is a great chance to ask any questions about ADT. He's going to catch us up on some recent work, a little bit of which we heard about at ASCO recently. Hank, where are you? Okay, I see. So ZAJIC, how old are you, Hank?
I'm 65 now. And since Z's and J's in the same word tend to get people panicked, it's Zajic. Afraid I just pronounce it for you.
Zajic.
Yep.
Thank you. Okay, we'll probably mess it up, but we'll do our best. Where do you live, Hank?
In Springfield, Virginia.
Oh, don't we have somebody else in Springfield, Virginia, or very close by? Yeah, Dan. Okay, there's a neighbor right close by here, Hank. When were you diagnosed, Hank?
My first kind of out of spec PSA was back in 2015. It was 6, just on a regular annual checkup. I was diagnosed from a biopsy in September of 2015 with prostate cancer, and that was Gleason 6 at the time. I kind of refer to it only as a partial biopsy. They only took 8 cores, and that's a long war story for why that happened.
But they took enough cores at least to get some Gleason 6 cancer out of it.
It had, yeah, of the 8 cores, one came up positive Gleason 6.
Okay, so it seemed like smooth sailing so far, but you're here, so it wasn't smooth sailing forever. What happened after that? Any treatment, or were you on surveillance?
So surveillance for about a year and a half. In the course of that year and a half, I did do a 3T MRI, which came out unremarkable. PSA kept chattering around in the 6 to 9 range. In March of 2017, PSA popped up to about 11.7. Had another MRI in April of 2017 and another biopsy. The biopsy, again, was Gleason 6, this time in 2 cores. The MRI indicated a bulge in the prostate. So without a whole lot of further ado between me and my urologist, we decided to do radical prostatectomy, which was in June of 2017.
Ooh, okay. And after the radical prostatectomy, the pathologist was able now to get all of your prostate tissue,
Right.
not just 8 little tiny cores. So then what happened?
Yeah, so that's where things started unraveling a little bit. The grading of the tumor was upgraded to a Gleason 7, a 4+3. I had an inked positive margin on that, although it was still, there was no indication that it had escaped, the cancer had escaped the prostate at that time. It was about a 2 centimeter tumor in the prostate. And within about 2 months of the surgery, my PSA started nudging back up. In September of 17, I had a ultrasensitive PSA come in at 0.07. And so that's when the radiation oncologist got involved. And I did 2 months of salvage radiation therapy from between December and January, December 17th into January of 2018. So that was
Okay.
EDRT 39 trips to the office.
They
All the
radiated.
treatment, by the way, my primary treatment has all been through Sibley Memorial Hospital in DC, which is Johns Hopkins affiliate.
Okay, good. When they did that radiation therapy, did they focus all their attention on the gland, or did they, recognizing that there was some cancer outside the gland, did they also do the whole pelvis, the whole prostate bed, or the pelvic lymph nodes, or anything like that?
So I never actually saw like a map of what they were doing, but they always referred to it as the prostate bed. So I think they were doing it a little bit broader than, the immediate area of the prostate.
All right. But when you had your radical prostatectomy, they took some lymph nodes out and they were all good, right?
Lymph nodes did not come out. Seminal vesicles did, and they were good.
Okay. No lymph nodes sampled during your radical prostatectomy. Okay.
No.
Okay. Okay, so now after your radiation therapy, a few months go by and we start looking for your PSA to disappear. What happened?
Yeah, so PSA was going along swimmingly well. I was doing ultrasensitive PSAs every 6 months, and they were all coming up less than 0.02. So I was, getting the magic numbers that we wanted all the way up through November of 22. For reasons I never really got a satisfying explanation on, at that point, my urologist shifted the test over to just a regular PSA test. And on the November 22 one, that registered a 0.07. And across 22 into early 23, it was chattering around between a 0.05 and a 0.07. I insisted on going back to the ultra-sensitive PSA tests, if for no other reason that I could at least be trending the data better, knowing that it was the same test methodology.
Yeah.
And 23 into early 24, it was just chattering around those levels, not really doing much. In March of 24, between the radiation oncologist and the urologist, we decided to go to quarterly testing instead of semi-annual. And since March of 24, it's been chugging up steadily at about a 5.5 month doubling rate. And I went biochemical recurrent in January with a 0.216. So I have not had a PSMA PET scan yet. That's scheduled for the 12th of March. So, I'm kind of on the cusp of hearing what the rest of the story is going to be.
So scan is pending. This would be your first PSMA scan, right?
Correct. Yep.
And your current PSA is 0.216.
Actually, I've had a second one since then. It's now up to 0.226.
0.226. Okay, time to do something, right?
Right.
Okay.
And we'll use the scan to figure out what that something's going to be.
Anybody do any genetic testing along the way?
Yeah, so I know this group focuses on the kind of the medical, the science, but truthfully, the getting close to biochemical recurrence freaked me out more than anything else in this journey so far, which is when I started looking around for the support groups, found zero first and then zero kind of not through zero, but through Jim Marshall, who I met in zero, kind of came over to this group. That's a long story to, in the support groups, I learned about Dr. Channing Paller, who is now my oncologist at Sibley, and she's doing the, I can't remember the name of the research that she's doing. But it's the Promise group. And so through them, I got genetic testing done in January. That came out with no indications of problem. And Dr. Paller has also gone back to get my prostate samples tested for somatic testing, but I haven't gotten those results yet.
Oh, good. Okay.
So germline is clean and waiting on somatic for an answer there.
Very good. And are you a vet? It sounds like you might be if you talk to Jim.
I am, and I am well indoctrinated. Thank you so much, Captain.
Now, it seems like you were able to go all this time basically saying, I have a very indolent, slow-growing, pretty safe prostate cancer here. It blipped up a little, but we slammed it back down. Now you're having a different kind of emotional reaction. And yes, we do talk about science here, but we have all been through that, everyone in this room. And we also have a group devoted just to talking about emotions. So you're welcome to join any of those things because now it's really hitting you that this isn't going to go away.
Right.
Right. Are you on any medications?
No, not yet.
Okay.
Yeah, no, the answer is no.
So Dr. Paller is going to look at these scans, these gene tests, and set out a treatment plan for you now that you unfortunately have to be considered to be recurrent.
Right.
Okay. And how did you pick this particular time to find us?
Well, like I said, just knowing that the doubling rate was kind of marching along smartly, 5 to 6 month doubling rate, all the literature I was reading is indicating that's more on the aggressive side. And it's kind of funny, at every bend in the road on this, the going in has been, okay, this isn't really too bad. And the coming out has been, oh, it was actually worse than we thought. And so now I'm kind of trying to get out ahead of that a little bit. Okay. And in the past, just because things were cooking along okay, I didn't ever really think I had much need for like reaching out to a support group. And this time it rocked my boat enough that it was like, I need to get engaged with other people on this.
Gotcha. Are you, do you have an emotional support system? Are you married, friends?
I am. Yeah. No, that's good and intact. Yes.
Okay. Are you still working?
Not as of September of last year. Yay.
Yay. Okay. What did you used to do?
Combination of 47 years in the Navy, part in uniform and part as a civil servant, and hung up my cleats in September of 24.
Okay. All right. And what would you like to ask anybody in this group right now?
I really don't have any specific questions. I have heard through Jim that this group is, gets into a lot of good detail. So I'm really here just to sponge right now because I know when I'm talking to the docs, I'm going to get all sorts of stuff thrown at me. And so I figure having heard it and prepping myself in advance is a good place to be. So
I
I
think
don't have
that's very
specific
true.
questions. I'm sponging right now.
And it sounds like you are by nature a sponge. You already have a fair amount of scientific knowledge about this whole process. So we hope you come back, and after you talk to Dr. Paller, you're going to have a lot to talk to us about because she's going to lay out a treatment plan for you that might involve medications and things like that.
I've had one session with Dr. Paller. My radiation oncologist was saying if we need to bring the oncologist in, and I was like, yeah, the heck with that. I'm bringing her in now. And I got through the waiting list of new patient, had a session with her, and she's terrific. I don't know how many people know that name, but
We all
it
know
was
that
just a
name.
real no nonsense. Here's the facts, kind of just a good, straightforward, no holds barred kind of conversation with her. So I was
That's
impressed.
our experience with her too. We're glad to have you be with her. Sometimes we're not happy with the people's medical teams, and
I'm going into this feeling very confident with her.
Yeah, we have a webinar. We did a webinar with her last year. I'll post it for you. And yeah, we refer to her all the time in your area.
Hank, that was Rick Davis talking. He's the founder of AnCan.
Hi, Rick. I've seen you in the veterans group a couple of times.
Yeah.
I'd like to open it up now to anybody that would like to comment, say anything to Hank, welcome him, give your own experiences.
I just want to let Hank know that Dr. John spent most of his working career, or half of his working career, in the VA as well. So he's you should be aware of that.
Yeah. Anybody else comments? I know we can all remember when we were in the same spot.
I had a quick thought that when you were getting your radiation, did you get any ADT at that point?
I did not. Between the radiation oncologist and the urologist, quite frankly, it never even came up as a consideration. And that was going on 5 years ago, and I really don't recall the circumstances on that decision. But it was just the radiation.
Jim?
Dr. John, I believe that you have, a Men Speaking Freely tomorrow night. Is that true?
Thursday, let's
No.
see. No, we
Next
had it last week. It's the week after this.
Oh, okay.
And I just also would like to add, for Hank's benefit and any other vets that might be on here, and with Jim's knowledge, we're really delighted that we're going to be starting a new group for veterans called Veterans Speaking Freely. It'll be a mixed group, and it'll do exactly what we do in Men Speaking Freely and Women Speaking Freely, except in this group, we will not be talking navigation, benefits navigation. We will not be talking healthcare navigation, and we won't be talking treatment. Anything else is open for discussion, and we're hoping to get that underway in March.
Richard Wassersug has his hand up.
Yes, I'm unmuted. I don't want to slow the process down, but I actually have to leave at the top of an hour for another prostate cancer Zoom here in Canada. I'm based in Vancouver.
Okay.
But it sounds, Hank, like you're going to be going for hormonal therapy, and there's some new information about that, and this is sort of an area that I work in. So I don't know, John, I can come back to that, but I do have to leave at the top of the hour. Tell me if you want me to talk about it now or wait till a little later. Do you get through?
I'm going to try to get to my next new guy, and then
fine. No problem.
Make sure that we get to you in time for you to talk to us. Matthew L. Where are you? I don't recognize everybody yet. There you are. Hi, Matthew.
Here I am.
What's your
Well, I'll
last
try
name,
to.
if
Yeah,
you're
go ahead.
okay?
Yeah.
What's your, are you comfortable giving me your last name? We have a hell of a lot of Matthews, right?
Lawrence, Lawrence.
How old are you, Matthew?
I'm 71.
Where do you live?
San Rafael, California.
Okay. And you're the guy that came through Jeff, right?
Correct.
Okay. Okay. Would you like to tell us when you got diagnosed and how that all came about?
May 2020.
And what
They had-
happened? A PSA rise or a symptom
Yeah.
or a rectal
The PSA
exam or
was
what?
normally around 3 for years, and then it started creeping up 5, 6, 7, 7.5, and that's what my urologist wanted to take some samples.
Okay.
And he found that, and I'll be honest with you, I'm not so clear on exactly what happened almost 5 years ago, but it was a Gleason 7.
You know if they called that a 3+4 or a 4+3?
It was 3+4.
Okay. There actually are some treatment decisions that are based on that. That's why we ask. Was there anything else on your biopsy besides the Gleason score? Any unusual descriptions or?
No, they didn't find anything else unusual.
Okay. What happened after that?
I sent the sample to John Hoskins to get a second opinion. They agreed. Then I went to get second and third opinions about what kind of treatment I should have. That was a very
Okay.
difficult time, 3 months, to try to figure out what was the best way for me to go. And I had my prostate removed in September 2020.
After you had your prostate removed, what happened to your PSA?
It went well. They don't do ultra sensitive PSAs through Kaiser, so it was less than. It was undetectable, basically.
Okay. And when they got that prostate tissue out of you, did they revise your Gleason score or your description of what was type of cancer you had or anything?
No, it was the same. And then what kind of cancer I had, I'm pretty sure that's there. The information somewhere in the hundreds and hundreds of papers I have on this.
Yeah.
I have to dig it out. I must have 4 folders on this.
Yeah.
But we decided, and I'm trying to remember what the surgeon said, but he said he checked 9 of the lymph nodes, and they
Yeah.
were fine.
Okay. Okay.
And it was a small cancer they found through the ultrasound, and it was on the right side of my prostate.
Okay.
But there was no evidence of going through the prostate bed.
Yeah.
But they removed the seminal vesicles anyway on the right side, just as a precaution.
Okay. And they were not cancerous, apparently, or they would have told you.
Correct.
And the margins of your resection were all clean, it sounds like.
Yes.
So you were hoping maybe to be rid of this for good. Then what happened after that? Now
So
we're 5
about
years.
4 years later, 4 or 5 years, about 4 years later, my PSA started going up very slowly.
Mm-hmm.
And then
What if,
I went and saw a radiation oncologist and talked to my urologist, and they felt that having radiation at this point to the prostate bed would be the best first solution to do.
okay.
I suggested doing the prostate bed and the lymph nodes at the same time, but they didn't want to do that. They just felt just doing the prostate bed would be the first way to go.
They were hoping that as a 3+4, maybe they wouldn't have to do any more extensive radiation.
Exactly.
Yeah.
And then
Okay.
I was on Lupron for 6 months.
Oh, you were? Okay.
Yeah. Oh, I did want to mention I did a PSMA scan, an MRI, an ultrasound. They did not find anything.
Okay. And now bring us right up to date. What's going on at the present time?
So I've had 2 PSA tests since my cancer treatment and since my radiation treatment, and so far it's been undetectable. I have another PSA coming up in about 2.5 weeks,
Okay.
and the Lupron is been still lingering around. I think I started the Lupron in July, and
Mhm.
it's still hanging around a little bit. The hot flashes are starting to go away, but the muscle mass was a big issue for me, losing that.
Do you have any idea what your testosterone level is like these days? Has it
I'm going to find
recovered?
that out in 2 weeks. Also, that's part of the test. I have to do that, testosterone and my iron at the same time. I do
Okay.
those 2 tests.
Did you become anemic or borderline anemic?
So in 1985, I had Hodgkin's disease,
Yeah.
and they gave me an incredible amount of radiation over a 2-month period. And it's nothing like it is done these days. They just kind of put you down on a table and kind of hit everything. There were special shields made for me, but it's not as precise as it is these days.
It
And
really
so I
has
ended up,
advanced a lot. Yeah.
yeah, I got thyroid disease,
Uh-huh.
and I started losing my hair, but after 2 years, basically everything started working again, except I've had chronic IBS ever since,
Oh,
and I still take thyroid every day supplements.
okay. Are you pretty much in the mid-range thyroid right now?
Yes,
Normal range? Okay.
yes, that's been tricky, but it's been pretty good lately. The last 3 years.
Now, when one question has come up, when you had to go back and have that radiation therapy, you had been running non-detectable PSAs. How
Yes,
far up did it bounce that prompted that radiation therapy? Like, at what point did they pull the trigger?
it started going up. I'm going to guess every 6 or 7 weeks. Went to 1, 2, and 3, and that's when my urologist felt it's going pretty quickly, and it's time to do something about it.
It got up to 3?
Yeah,
Oh, okay. Yeah, that's pretty high after a radical prostatectomy, isn't it? Okay. Um, I'm wondering, I mean, I really am welcoming you to group. I think it's great that you're here. You may fit into a different group better. I don't know. I'm going to ask Rick about this right now and see if he thinks you'd be better in a lower risk group or not. Rick, do you think we're good here?
Yeah, I mean, any sort of recurrence should be in this group.
Okay, so it was okay.
Any level of recurrence belongs in this group, and I think the issue, Matthew, is that you've got to watch where you are right now pretty carefully, and you've done 6 months of Lupron. It can take at least 6 months to come back, if not a year. So don't be surprised if it doesn't come back that quickly. But we've just got to stay on top of it to make sure that you don't need more treatment. And they're sort of doing it in stages. Where did you go for your radiation treatment? To South San Francisco?
No, Roanoke Park. There's
Roanoke Park. Okay.
Treatment
Okay.
center up there.
Yeah, I had the choice to go to Roanoke Park at the time, but they also said you could go to UCSF, and I jumped at that. But now they don't send you to UCSF because they built South San Francisco, which has the best equipment. Dr. John hasn't asked you, but I know he's going to, so I'll jump the gun. What sort of genetic testing have you had?
I had the BRCA gene tested, which I don't have. Does that sound right? The BRCA gene?
Yes.
BRCA?
Well, yeah.
They
Hopefully it
test
was.
for others as well.
Was it just for the BRCA gene, or did they test you for all inherited mutations?
Inherited mutations.
Okay, and nothing came up.
Correct.
Oh, that's great. Okay.
But the reason I went in there is because it was mentioned that they wanted to know if I had the BRCA gene or not.
Yeah.
And I never
Yeah,
had a decipherance.
They're actually interested. I mean, the BRCA gene, because that's what you hear about, but there are a number of mutations that are of concern.
Are you
But if we
never
started
had
talking to you about ATM, if we started talking to you about ATM or MSH1, you would wonder what the heck we're talking about. So we don't do that.
Matthew, are you a veteran?
No.
So your current main doctor, who's your quarterback now?
From a urologist? Is that what you're thinking? Or
Yeah.
Yeah, you don't have an oncologist, right?
yeah, I see Andrea Hartsock.
Oh, you
okay.
do? Great. Okay.
I talk to her when I have questions, and she keeps an eye on things. And then my urologist, Jay Belani.
Okay. Was it, I'm curious, was it Belani who brought in Dr. Hartstock? Or how did you know to get Dr. Hartstock involved?
Through a group I was, it was talked about. She was talked about quite often as being one of the best, and so I asked if I can see her.
Yeah. Well, we go back a long way with her. So does the Marine group go back a long way with her. We worked with her when she was, both I and the Marine group worked with her when she was at UCSF before she jumped over. And she's kind of a standard referral for us for people who are in Northern California. And she's really great. We like her very much. So it's really good that she's already on your team.
Jeff, would you like
There
to
was
say
also
something?
a Dr. Selly, but I choose to have my radiation in Roanoke Park instead.
Okay.
Jeff?
Yeah, hello, Matthew. I've also Kaiser had my surgery in 2010 and radiation 3.5 years later. I was just wondering. Also, I have Heartstock just like you. I thought I probably recommended it when we talked about in the other group.
Yes.
I'm wondering. I thought you said your PSA started rising to 0.07. Did you say that? Because
That
you
was
said
it.
it went to 2 or 3, and I know Kaiser at 0.2 wants to do the radiation, not at 3. Did they do the radiation at 0.3, not 3?
Yes, that's correct.
It
And
was
I'm not good about where the point goes, but I have.
It was 0.3. When it hit 0.2, they said do something, and because that's how
Yeah.
Kaiser does it. They
Well, so that's when I had all the tests done, the PSMA tests and MRI and sonogram. I had all that done.
no.
So that was 0.3.
Yes.
Thank you, Jeff. That's good to clarify.
Jeff, do you attend the Marine group?
No, but is it the USCSF group or maybe the CSC
Okay.
group that I saw him at,
Okay.
or Mayo, one of those three.
All right. Well, welcome to group. I'm going to see if anybody has any comments, and then we're going to hear from
I do want to
Wassersug
mention,
before he has to go. Go ahead.
I did not have a Decipher score because Kaiser they wouldn't pay for it and they didn't think it was necessary.
Mm-hmm.
And the genomic test I have not had done either.
Okay.
Did you have any questions for us as well? Because I know we're sort of a bit under the gun here. So.
Well, no, I mean, this is all new to me. It took me a while to figure out how to get to this website, get here, as you know. It was a challenge. So anyway, here I am.
Okay. Well, welcome. Do you know our schedule? We meet every week.
Is it
Except
every
for
week
the
or
fifth
every other week? I thought it was,
It's every week other than the
Okay.
fifth week of the month. It's the first Monday, the second Tuesday, the third Monday, and the fourth Tuesday. And if you take a dive into AnCan's schedule for high risk group, you'll find it there. And
Okay.
as you get this next round of blood tests, we would definitely like to talk to you again and see where this is all going to go, because now you're off ADT. And now we're all on the edge of our chairs wondering what's going to happen.
Yeah, including me.
Yeah.
And then
All
I have
right.
an appointment. I have an appointment right afterwards with my urologist.
Okay. Do you actually have an appointment with Dr. Harstark, or do you just informally call her when you have a question, or what?
I informally call her when I have a question.
Okay. Okay.
I did see her in person, though, also.
Hey, my urologist dropped out of this years ago when Heartstock started. I'm a little surprised you're still talking to urologists since you just had radiation. Heartstock's really the one to talk to from now on.
Well, I'll be talking to her. I'll be sending her stuff.
Okay.
And she has access to all my records.
Okay. Yeah, eventually we would like to see her calling the shots, writing the orders.
Okay,
Would
thank
you put your email in the chat if you figured out where that is?
We have it. We have his
We have your
email.
Okay.
We have the email. He's registered to sign up. Jim Marshall has put some information, but please make a note that the times are different. The Monday night times and the Tuesday times are not the same time. So just check it all out. You'll see it all there.
Okay. Is that
Okay, Dr. Wassersug is going to catch us up on some research about ADT, which is going to save me from presenting it to you because we heard something about it at ASCO. And then if he still has time before he has to go, anyone that has any questions about ADT is welcome to ask them. Go ahead, Rich.
I have to leave in about 8 minutes. First of all, let me say hello to Rick.
I know.
I've known Len from these groups for about, 5 years or more. and some of you others may know. So I'm a prostate cancer patient who was diagnosed over 25 years ago. I failed prostatectomy. My first PSA test was 19. I failed the prostatectomy. I salvaged radiotherapy because my PSA kept climbing, and after that, my PSA kept climbing. So I was on Lupron, didn't like it, and after a couple of years, I went over to an experimental program, which I do not promote in our book. The book, if you don't know of it, Androgen Deprivation Therapy is the name of the book. I've done research on with rats, with humans, on related to adapting to hormonal therapies and such. So I come in as an academic. I'm not an MD. I'm a research scientist, and the protocol that I went on is high dose transdermal, which is female estrogen. That in transdermal means absorbed through the skin. And there was a major study that just since the fall is now reporting its results. I've been in contact with the group. They spoke at the European Society of Medical Oncology in the fall, and they presented as well at ASCO GU about a week ago. And I was going to ask you guys. I know Rick, you were there. Did you get to go to Nick James's talk and hear it on the patch study? Okay. So
yeah, we heard it. It was right at the very end. So, but we heard him talk along with the gut molecular stuff. Right. Remember, Dr. John? Do you remember it?
Yeah.
So here's the situation, and it's very quickly. Although I do not promote this because I was waiting for these results to be in, I was on the protocol before the study ever began. And it's called the patch study because the source for the transdermal estradiol is these simple patches that women can take in menopause to control menopausal symptoms. But if you get enough estradiol, it sends the signal from hypothalamus in the brain to the pituitary gland to the testicles to shut off production of testosterone. And now they're reporting the results of the patch study, and they're remarkably good. The transdermal high dose estradiol controls the PSA as well as drugs like Lupron. And when it's combined, this was a new study, when it's combined with drugs like abiraterone, it still has as good a control. For people like Hank, who may be thinking about this, here's the good news. This has no hot flashes. It preserves bone density. The patch team, the research team, has published that already. But I actually recently got a DEXA scan, and after over 20 years in these drugs, my bone density is absolutely normal. Now, there are other considerations. High dose estrogen can cause breast development. And I have a little bit. That's how much men can tolerate that, we don't know. But I am engaged with trying to get this out because one of the problems with this is it is not a standard of care. In the UK, where the patch study is based, they are going forward to try to seek what they call a repurposing. Say the patches are already available, so we've shown it's safe for men, but they have to go through a lot of hoops. And I just heard from Nick James's video on his talk that they are going forward and they're starting to be promised. So this is promising that they will get repurposing and get this approved as a standard of care. So it is something to consider for a form of ADT. Our rat work suggests that it will reduce daytime fatigue. It will preserve some aspect of sexual interest. It will preserve REM sleep, which is where dreaming takes place, and which is important for preserving cognitive function. Not all those data are yet in for humans, but this is an option. I'm getting an echo here.
Yeah, I hear it too.
I don't know who's got a mic open. Okay. Well, if you do,
can everyone please mute just in case it's.
I've taken care of it. It was Herb who just came in, and we'll sort it in a minute.
All right. So
go ahead, Rich.
All right, two or three last points. One is it's not a standard of care. You can refer to your doctor if they say, well, I don't know how to administer that. They can go to the patch study reports that were presented as abstracts at ESMO They'll be presenting next month at the European Association of Urology. It's called the European Association of Urology meeting in Spain. And I and a couple of other colleagues are going to be presenting a poster at the AUA, the American Urologic Association, all to try to get the word out that this exists. Now, what it's going to take to get it to be a standard of care in North America is another issue. And there are a lot of little variables about monitoring patients. We don't know whether the doctors are going to be willing to produce this, or offer this, because patients who try this should be well monitored. Going back to my N of 1 myself, I now use a gel. I don't use the patches. And I now have my ADT costing me less than 40 cents Canadian, which is about 30 cents US per day, which is way down below what the standard LHRH drugs like Lupron. And if you add in the antiandrogens like Nubeca and Xtandi and so forth, it's way cheaper. It could make ADT available in countries which can't afford it. However, once again, it's not a standard of care. One other thing to consider is that because it is an estrogen, if you have a cancer that's sensitive to estrogen, it may be a problem. The patch study did not find that to be true, but they also were not doing genetic screening. I'll stop there and ask if there's any questions, because I, in theory, should leave in 1 minute. Rick, anything you want to add to that?
Or anybody else, questions about not only patch, but any ADT questions while we got him here?
Okay, well, I can tell you, 20 years of no hot flashes is worth it. Okay, I have a Gary, yes.
I have a question.
Oh, okay, Jack, yes.
Yeah, tell me, Richard.
Jack.
How does your testosterone show up when you use estrogen rather than ADT? Is it higher?
I get it checked regularly, and it's now well below. It's been forever well below castrate levels if I stay on the estrogen, and I've got it. If I dose it correctly, I can get down to very low levels, like those that are suggested. So I'm doing fine. Got complete testosterone control.
How about you,
I have
Steve?
a question as well.
Wait, let me just go to Steve. He had his hand up. Go ahead.
Yes, what I only had two quick questions. What exactly constitutes high dose? And the other question is, what is the approximate monthly cost for that? I know you mentioned a price per patch, but what's
Well, just take say it's US. Take 30 cents times 30 days, and you'll have the monthly cost.
okay?
All right. So
What's high dose?
a high dose. So it turns out this had to be worked out at the beginning of the quote patch study, and these guys are using 2 or 3, and in some cases 4 patches, and changing them twice a week. So that's much more expensive than using the gel, and it has to be monitored because it's not the same for every guy. So this is where there's going to be an issue to the doctors and the patients. You're going to have to get more blood tests to get to the right level. It isn't just here, take these patches and go home. So there are monitoring issues. And now one thing that's going to happen is that we've got a questionnaire we're going to be sending out throughout Canada and the United States, asking patients, if you had this option, would you be interested in it? If you had to pay for it out of your pocket, because it is off-label, you'd have to pay for it out of your pocket. Would you be interested? And my urology colleague on the thing said, you got to ask one more question. How many doctors would you be willing to pester to get this option? Because this could be a real burden on the doctors, and we want to make it a standard of care and not turn all these patients to be pests and then just irritate the urologists.
What is the ideal estradiol level you're shooting for with this patch?
Yeah.
It depends on how you measure it, but I try, and the range can be huge. I tried to be in the mid-range for women, and it depends on what scale you use. A mid-range for women premenopausal, okay? Because if you get too high, you could be in the risk of blood clots, and that's why you don't want to take oral estrogen. It could cause blood clots. But on the patch study, it was huge. The range was from, I think, 200 to over 1,000, and anywhere in there it will achieve castrate levels.
It's 8 o'clock.
Yeah, I
do have a couple more guys, but I have to let you go.
Thank you.
Thank you so much for coming.
Thank you for letting me speak about that. Thanks. Bye, guys.
Thank you.
Let me catch up and see if we we can substitute for him a little bit. Gary, did you have a question for Rich?
I did. I'm wondering, since it's not standard of care, how do you get your doctor to, assist you in trying this approach? Won't
The doctor just, it's not like the drug's not available here. It's easily available. You have to, if you and your doctor decide it's a good idea and you've read the study together, the doctor has to write the prescription. There's a question of what insurance will do, but at that price, it doesn't really matter.
That the doctor has to write a prescription for prescription strength gel?
Yes, it's patch, like a nicotine patch.
Okay.
See, Jerry Grimes just put up a note saying his insurance didn't cover it, so it doesn't look like it's very promising for insurance to cover it. Okay, that was Jerry before. Other questions that would have been for Rich if he was still here? Sorry. Len?
Yeah, John, I don't know if you know the answer to this. I would suspect if he has castrate levels of testosterone, that it would have the same effect on muscle atrophy, but do you know the answer to that?
He says there was less muscle atrophy. He says that he can still exercise a lot. He gives examples of people that he knows that have exercised very vigorously. And I can pull up my notes on the study that he's referred to see what they say about muscle atrophy as soon as I get a breather.
Okay, thanks.
I'd be curious if there's anybody in this group who's on ADT who would be willing to risk switching right now.
I would.
I think I would, but I would probably ask about pre-radiation to the breasts because I'm not a guy that can tolerate that, I don't think.
Are you worried you might
Robert?
spend too much time in the shower?
Yeah.
I did have the pre-radiation to the breasts before I went back on ADT this last time.
Oh, you
And
did?
yes.
Oh.
Yeah. Part of that was because when I had a metastasis, when it metastasized, it was to a lymph node in my chest. And so my young oncologist said that it really wasn't necessary, that the drugs, weren't that bad, but it already happened the first time I was on it for 6 months. And when I was referred to another oncologist in my area who was like a young 72-year-old, he said that it was normal practice back in the day when they did castration, that they would actually do the radiation to the breast to prevent it. So I don't know where it's going so far. I can't really tell, but I did have it, and it was no big deal. And I guess I would recommend it. It hasn't caused any harm. And it was 3 sessions. It was no big deal at all.
The radiation actually shrink whatever gynecomastia you have.
No, it just stopped it. It stopped it from progressing. And the thing that the older radiation oncologist who actually did it said, he said that the reason that my breasts were different sizes was because I already had radiation to one breast for the metastasis in the ileum. And he said, had I not done it, that one would have grown consistent, more larger than the other one, because there already was some radiation to one side of the chest. So they're evening out.
And here are my notes, typing madly away during ASCO. Didn't weaken bones, less fatigue, less sexual effects, no thromboembolic events, less hypertension, less hot flashes, small sample. I didn't catch a word about muscle atrophy.
Was there concern about blood clots, though? I thought I picked up something about that.
There's always a concern about blood clots when you're talking about estrogen, and yet it did not emerge in this study, no.
I think the concern of blood clots is if you're taking oral estrogen, but if you're taking the patch, that I don't think it's an issue. Is that right, John?
That's what I understand. I don't really know why it should be that way, but
It doesn't go through the liver.
yeah,
Right.
the liver must alter it in some way to protect you. Okay, guys, I'm going to start down the list, okay? Took, you were first.
Hi, Dr. John and everyone. I just wanted to give an update on my treatment. I ended up getting the HDR Brachy boost in December last year through Santa Clara Kaiser, and I just wanted to praise my RO, Dr. Matthew Scala. I'm not sure if he's been on any of your lists be, before, but yeah, the procedure went well, and it was less painful than my biopsy. So had 18 needles through my prostate, and they put me to sleep, and before I woke up, the procedure was done. So that went well. And my last two PSA tests have been undetectable at less than zero point 0.1. But I had my second Lupron shot, and now I've kind of getting like a really stiff index finger, like in the afternoon. Is that what you guys call trigger finger, or is it, or
It's
is it?
probably going to turn into it. And this is something that I have heard a lot about in this group, and apparently it's quite common in people on ADT. I've had um, maybe 4 or more injections into my hand for this. What happens with the trigger finger is that when you hold your hand and then you try to open it, the finger locks, and you have to push it, and then all of a sudden it springs open. You may be on the way to that. I don't know. You know, a hand surgeon
My fingers
will.
just seem kind of stiff though, so and it kind of aches a lot just in the afternoon. So I was just curious
Yeah.
because I was part of the ADT on Lupron.
One
And
possibility is that you're beginning to develop it. Now, my personal experience with trigger finger is I don't get pain until it's fairly long advanced. But you already have aching before you even are starting to get the triggering phenomenon. So, anybody else? Can anyone else contribute to this discussion?
I've had the trigger finger. I've had 4 fingers treated already. The last 2, the 5 fingers, the first 3 they treated with surgery, opening up the path that that it goes through, that where you get a little swelling in your hand, so you get that bump. But the last 2, he just gave me cortisone shots, and they've actually stopped it. So surprised the same doctor didn't recommend the cortisone shots at first, but he started pushing it, and we tried it, and it worked. Had a
If
little
it keeps
bit
on
of,
advancing, Took, and doesn't go away on its own,
no, it
then
doesn't. And it for me, it was painful almost from the beginning. You bend the finger and straighten it, and it hurt. Then you could feel that pop in that spot.
yeah.
you
For
can
me,
So
kind
it
of
was
like exercising or
the doctor
diet.
that does this treatment is a hand surgeon, Took.
Yeah.
So when it gets to the point that you're sick of it and you're sure it's not going away, you call a hand surgeon. Alan?
Yeah, so I have the trigger finger, and I went to the hand surgeon, and he gave me the shot. But I didn't go back to him, and it hasn't gotten a lot better. But he wanted me to lay off exercising for 3 weeks, and that didn't sound like fun to me. He said, "Oh no, you can't go to the gym, you can't climb," and so I'm just waiting for it to get worse, and then I'll go back. And I hope that I'm not messing anything up by doing that. But
I was never told that to do that.
There was Rick?
So I've had this before I was even diagnosed. And I once got a shot at Kaiser. It did absolutely no good. I'm not sure it has anything to do with the ADT. I think it may have.
Really? Really?
Well, because I had it before I even started. I now have it literally all the time. It's never painful other than when I open my finger, I have to use another hand. I wouldn't want to be climbing with it because sometimes what happens is you grip something and then you can't undo the grip unless you've got a free hand. Well, when you're climbing, you don't always have a free hand, or you can't take your thumb and just open it. But a couple of times it's compromised me, but it's never been painful, but it's been uncomfortable, and I just live with it.
I've had it for so many years, off and on, and I was a serious golfer, and I think that contributed to it a lot. And I've had it injected multiple times, and it was relieved. And he got to the point he no longer would inject because he said you can start ripping your tendons. He said I would just do physical therapy, but it got worse in the past 2 years while I've been on ADT. It's never gotten to the point where I can't close my hands. So I did a literature search, and there are lots of people who've reported that who've been on ADT. So you're not alone, and I've had it, and many other people have had it also. But it's not just a trigger with me. I can't close my hands, and they're swollen like sausages. So I'm hoping when I take a holiday that it diminishes.
It may well be affected by ADT, and since I had it before, I didn't sort of associate it with it. Maybe it made it worse. I will tell you, it is kind of interesting because I noticed that I get it more after I've been rowing. Yeah. So it's sort of
all that gripping.
Because obviously when you're not supposed to grip. You're supposed to be like a hook, and you just pull, but you do grip. You can't help it, and I think that. So I think it may be an impact. Hopefully there are no rowing coaches on this screen, and there are no rowing coaches going to be listening to it to criticize my form, but we'll see.
Steve? The surgery works really well. They just open up the channel that it gets caught on, and I've had 3 fingers done that way, and I've never had it come back.
Yeah. But how long were you out after the surgery? How long were you?
Very little recovery, a week, maybe. I mean, you never even really notice it. Your hand is fixed immediately after the surgery.
Mine actually took several weeks to stop hurting after the surgery.
I was offered both the surgery and the cortisone options, and before I could make a decision about that, I switched from Lupron to Orgovyx. And to be honest, the trigger finger's gone. I'm not saying that's an Orgovyx thing. I just noticed within this last year that I don't have that problem anymore with the trigger finger.
Well, that's interesting.
I thought that was interesting too.
So I have a quick question for Took. What was the name again of your HDR radio RO in case we have to recommend him?
Yes. His name is Matthew Scala. I think he came from Memorial Sloan Kettering.
Okay, great. Thank you.
Yeah, he seems like pretty up to date with the latest studies and stuff. So I'm pretty happy with him. And since I'm from Southern California, it was well worth the trip up to Santa Clara.
Thomas, you have your hand up? I'm sorry.
Hold on a minute, John. Where was this guy based? Up in San Jose?
Yeah, he's out of the Santa Clara Kaiser.
Okay, thanks,
Santa.
Doctor.
Okay, sure.
Great, thank you.
Thomas, what you got?
Yeah, hi. I got a question here about the former discussion regarding trigger finger. Does this get confused with Dupuytren's contracture or Dupuytren's contracture? Because I have that condition, and I've heard about the trigger finger. Are those separate things in the
Yes,
minds of people in the group?
separate
Very,
things.
very separate.
Okay, that's
Yep.
all I need.
Okay,
And
good point.
treated differently too. But
So I
Dupuytren-
have both. So it may be separate, but it can have both. You can get both of them.
Yeah, but you use collagenase with your Dupuytren's, and you don't use collagenase with your trigger fingers, and it can make a difference if you get that injection of
Yeah,
dissolved
fortunately,
collagen. Yeah.
mine's never gotten too bad. It's just real obvious.
Okay.
Thank you.
Oh, Phil Zaremba, you have the floor.
Okay, yes, thank you very much. I have a question. It's been actually a couple of years since I've been on this, and I know I've gone through radiation a little bit of, only about 5 days. I've had chemo. My PSA score at the time that was found was 1,120. And I have been on Xtandi and Eligard. Eligard, I do the shots every 6 months. And I've been taking Xtandi now for, I do believe I started it last in 2023. And in 2024, about a year, it started showing signs where it wasn't, my scores started going up in my PSA. And I know in the past month, they're still real low. I'm looking at my second last one was 0.657. But my last one after that went to 1.545 for my PSA score. And they sent me for a PSMA PET scan, and it didn't show anything. Matter of fact, the radiation guy says, "Oh yeah, you look real good. I don't see any cancer." And my regular oncologist said, "No, I believe it's still there. It just didn't show up in this PET scan. Maybe, with my score so low, he felt it just didn't show up." Well, then again, when I had the PSA, because before I went, it was 0.657, and then I had the PSA of 1.545. That was after I did the PSMA PET scan. And so I saw him today, and I know he's not changing my medicine or anything at this point. He's still has me on Xtandi and Eligard, even though he says the Xtandi isn't working. But he's going to have a CT and bone scan. I want to have that done next month early. And, I think we're going to take a look at, what's going on from there. I was just
So I
wondering
don't
what
know
your
your
feeling on
history.
that.
Have you had a radical prostatectomy?
No.
Okay.
So
So you're Nate. You're
I
low.
have his history.
Oh, great.
Okay, I'm just putting it in the chat window. And let me put it in whilst you read it. I'm sorry. I put that in for everybody. I do apologize, Bill, but I'm sorry about that. It was supposed to go to Dr. John.
So where's the nadir on here then? Biopsy, bladder, Eligard.
So
This is
my concern is this. We originally we suggested to you, you need a genitourinary medical oncologist on board, and I'm not sure if you have one. I know that are you still seeing Dr. Chawla?
No, I'm seeing Dr. Zarzor.
Okay. Is Dr. Zarzor a genitourinary or is he a general medical oncologist?
I think he's a general medical oncologist.
Yeah, you got to get yourself to a specialist GU medical oncologist, especially since we're having trouble seeing where your cancer is. What type of insurance do you have?
It's Medicare Advantage plan there.
It's in a Medicare Advantage plan. In
Yes.
that Advantage plan, do you have any access to centers of excellence?
To what?
Centers of excellence. Can you go to the Ohio State James, for example?
Oh, I don't know. I haven't looked into that.
Okay.
I will look at. I'm with Aetna. Aetna is my plan on that.
Right. See, the problem with these Advantage plans is that you're limited in who you can go to, and you have to stick with somebody in their plan. On the other hand, if they don't have a qualified genitourinary medical oncologist, then you have a good chance that they will approve somebody. And you've got to get yourself to somebody at the James or somebody at Cleveland Clinic or somebody at the University of Chicago or somebody at Ann Arbor, Michigan, University of Michigan, where they have these doctors. The general medical oncologists are shooting in the dark. For example, what I'm probably would have, first of all, for it to get to 0.65 without a PSMA scan is against the guidelines. To get to 1.55 and your doctor say, well, it isn't high enough, tells us he doesn't know what he's talking about. What is more likely is that you might not produce PSMA. That's a possibility. And so you might want to redo this with an Axumin scan, because at 1.65 you're well. And before he does these bone scans he might be doing an FDG PET. That's not a bad idea. Bone scan, I doubt, is going to help much. But what I think, I shouldn't say that. If you don't produce PSMA, the bone scan may show something. But I think the next test I would do, if you didn't show anything on the PSMA, was I would be asking for an Axumin scan.
How do you spell it?
AXUMIN. AXUMIN. And the reason is this: the PSMA scan requires that you show this protein PSMA, prostate-specific membrane antigen, that you express it. Not everybody expresses it. Somewhere around 15 to 20% of guys don't express it. So the fact that we don't see anything on the PSMA scan may just be because you don't make PSMA. On the other hand, we can do a bone scan, we might see something. We can do some other type of CT scan, hopefully an FDG PET, that may show something. But the other thing that we can also do, which is pretty simple, is to give you an Axumin scan, which is a different type of scan that might show something up at a level of 1.55.
Which I would have now, yes.
That's what I'm saying. Okay. I mean, it should show up at 1.5 or greater. You know, I can't remember the cutoff. Len, can you remember the cutoff for the Axumin? It's usually over 1, isn't it? Over 1.0?
Yeah, between 1 and 2.
Yeah.
I'm about an hour, 20 minutes away from Ann Arbor, from where I'm at here. Is there somebody over there that you recommend?
Let me take a look. It's gone a little spotty over there. but let me take a look. If not, I can certainly get your name I can certainly get your name for at Ann Arbor. But let me just take a look and see. So I think the guy there is Smith that we use, but I can't remember. I need to look. But let me take a look. Let me throw it back to the group to talk to you about what sort of scans you might want to get next.
And
Bill,
comments?
Yeah, Len?
Yeah, Bill, did you have genetic testing done?
Yes, I did.
Negative?
I did. I had one thing pop up, and don't ask me what it is now. I have to go look it up. But yes, I did have something pop up on me.
Okay. I told you it wasn't actionable.
That I can't remember.
I'll
when I come on next time, I'll have the report.
Yeah, look it up.
What's that?
Do look it up. It could be important.
Okay.
It's in the notes. It was CDK12.
Oh yeah.
Okay.
Which isn't. It's kind of actionable, but not really. So, I think there's something new that they're looking at that might directly affect CDK12, but it's not going to be actionable by a PARP inhibitor. But yeah, I have it. No germline somatic showed CDK12. It's in the notes if you look at the notes in the.
Right.
The other thing I would say to you, which also gives me a little bit of concern, is you don't want to be getting 6-month Eligard shots, Bill. At least I would not get. Can't give you the medical advice, but I wouldn't get a 6-month Eligard shot because our experience has been that they can tend to wear off early, and you don't really know. Where are you in that cycle of your Eligard shots?
I just had it done within the past month.
So it could be that the reason your PSA has gone as high as 1.55 is because the Eligard shot was wearing off. If you got that Eligard shot, if it was at the very back end of the Eligard shot, that 0.65 and that 1.55, and it may be that the new Eligard shot hadn't taken effect. So we got to be looking at that. And you're better off with 3-month shots. Don't let them give you, well, I can't say that. I would not have them give me an Eligard, a 6-month shot. There's no reason for it.
It also comes in a 4-month too.
Yeah, in the 4 months, 3-month, 4 months. But we've seen it before where, and different men work differently, but you may not have had any ADT in your system in the 6th month, and that's why your PSA has gone up. So that's another thing to look at before. Once you're in about 6 months with this new shot, go in and test. How often do you test?
How soon do I test for the?
How often do you test?
About once a month right now.
Okay, that's
for
great.
The PSA.
So, yes. Yeah. So stay on that once a month and see if you might see a downturn, because it might be that you just were out of ADT in your body.
Okay. It just makes me. Nope.
Rick, I was just looking at some notes I had from an FMI profile. I don't know whose it was. It wasn't mine, but they said CDK12 inactivation can result in tumor immunogenicity increasing, and therefore possibly a case for using checkpoint inhibitors.
Yeah.
I have a note about that also. That might be a possibility for Pembro someday.
Yeah.
Good point.
So what we're saying, Bill, is that you might be a candidate for immuno-oncology. We think that it could be. I think that's probably what I was where I was remembering it. You may be a candidate for immuno-oncology, but again, you got to get your ass over to Ann Arbor, and I'll put something in the chat window for you. I'll give you a name. I'll put a name in the chat window for you.
Okay, thank you very much.
Okay, follow up with us. I'm going to move down the list. We probably have more people than we can do in a half an hour, so let's not be too lackadaisical about it. Brian, I got you next.
Good evening, guys. I'll try to keep it quick. Batteries are dying, so if I drop, it's not because I don't love you guys. Okay. Full disclosure. So first thing I want to say is thank you, Rick. He sent me to UCLA to meet Dr. Reddick, who accepted me as a new patient. I also talked with Dr. Kaysen, and he's the radiation oncologist. I should say for Bill, I have kind of a similar story that my PSA started going up from 0.1, 0.12 to 0.5 in January last year. And then it kept going up, and they did a PSMA PET when it got to about 6, and nothing showed up. And then it kept climbing to 9 and 12, and they did an FDG PET, nothing showed up. And I was scheduled for an Axeman scan, but then my urologist at UCLA, before I hooked up with my MO, he said, I want to repeat the PSMA PET. And sure enough, I had the membrane antigen. We found it. I was immediately started on the Eligard shot, which I failed. But they also added Xtandi, and the Xtandi took my testosterone my PSA from, let's say it was almost 20 to 1.4, and that was in presence of a normal testosterone. So I failed the Eligard. They quickly put me on Orgovyx, which I asked for in the first place. That was insane. I have very few side effects other than fatigue, no hot flashes, all that stuff. But I did have to let my PSA go up quite a bit until we were able to find it. So I'm oligometastatic. I got a cluster of nodes in my retroperitoneal area, just about the level of the kidneys anterior to the spine, and then one up in my supraclav. So that was about 6 months ago, and on let's see, today's Tuesday. So on last week Tuesday, I had a Zoom visit with Dr. Reddick. He is a genitourinary medical oncologist, by the way, and I wholeheartedly agree with Rick's recommendation to go find one. Anyway, he looked at my labs. I had drawn the couple days prior to our meeting, and testosterone undetectable. PSA was 0.01, and up in Idaho, we don't have ultra-sensitive PSA testing, so it could be lower than that. That's just as low as the machine reads in Idaho. So he said to me, you know what, I think we should start our holiday now. And I said, well, wait, you told me 9 months. And he goes, I don't think we're going to get better than this. Let's take the holiday now. I said, okay. And then I asked him about the genetic testing because I was able to track down my biopsy tissue from January of 2021. Sent the fax phone for UCLA to call to grab it. They sent it to their lab. The genetics testing showed no actionable mutations, but I asked him if there were any inactionable. He said, yeah, there's 2, and he named which ones, and he said, this is like very common, especially in like 40% in Caucasian males. So all that tells me is, yep, we have prostate tissue. I said, fine. And so, the week has gone by and I'm already feeling better. Now I have a little more energy. I'm I'm kind of looking. I'm working right now. I'm still working locums. I'm in Colorado right now. I come down here to help a surgeon out every few weeks. So I'm here for 2 weeks. But Rick, I can't thank you enough for putting me together with that dream team, and I'm so grateful that they accepted me as a new patient. And so at this point, it may just be whack-a-mole. I know I have the membrane antigen, so I know I can find it again. But I had to sit back and not take any Eligard or Lupron or Orgovyx or any ADD products until we could finally find it. And oh, by the way, after I started the Orgovyx and Xtandi, 3 months later, I went down to UCLA for a repeat PSMA, and the two words put together that I zeroed in on, because you're reading a radiologist report, which can be a little confusing, but it was interval resolution, mentioned twice. So interval resolution of my superclave, the interval resolution of my retroperitoneal nodes. So, but they had mapped it out. My concern was my brachial plexus, because those structures are very close, and resident was very nice. He pulled up some imaging, my images, and this green is your plexus, this magenta is your lymph node. So there's a little overlap, and we just draw it that way just to be super cautious. But and sure enough, when the beam would come over, it would stop, and maybe the shutters would change a little bit, and it would rotate, and then it would finish the sweep. But I'm very hopeful. I'm very grateful to all you guys. And Rick, one last final on a personal note. My daughter, if last week wasn't great enough to get my holiday started, on Thursday my daughter had her interview at Idaho State University for PA school, and within 2 hours of the interview, they emailed her welcoming her to the program. So she's going to be a physician assistant in a couple years. And so I'm super happy for her. And, this has just been a really great week. And work has been going great. So I'm happy.
That sounds pretty good, Brian. It's kind of a surprise that you got a holiday so early. Just be monitored very closely.
Yeah, every 3 months he said, we're going to be monitoring you. But the good news is I responded so well that, he's not afraid to shut it down 3 months early.
Steve, you have a comment quickly? Got to unmute, Steve. Unmute, please.
Yes, thank you. Brian, I may have understood, but what is your PSA when you're starting your holiday?
0.01.
Okay.
And that's not an ultra sensitive. That's as low as the machine will read.
I have the impression that it was actually read as less than 0.01. Steve.
Mine was reported. I have to go back and check that. But again, I have my labs drawn up here in Idaho, but I have all my scans and all my treatment performed down at UCLA. And that has worked out great.
Good question.
Yeah.
Is Lee still here? No? Okay. Steve Rue, you had you wanted to bring up something. I know he was here a few minutes ago. Steve? Okay, nope. And Dan, you said maybe. Check with you when the time came.
Yeah, it's interesting because of what Dr. John put out, earlier in the weekend. So I emailed Dr. John just to give him an update. And for you guys, I already had an x-ray of my hip. It comes back that I've got osteoporosis in the spine and osteopenia in the, hip and neck. And then they did a bone density scan and wanted to get me onto Zoledronic. They did the C crosslink collagen type, and it came out 649. They still haven't decided on the zoledronic acid, but does anybody have any experience with the crosslink collagen test that they did, blood tests?
Just to catch people up, see, crosslink is something that is indicates osteoclastic activity, which, as you all know from my write-up, actually absorbs bone because bone is constantly being turned over. So if osteoclastic activity is elevated, it gives you an idea that you're on the negative side of the balance. So, my thought with Dan is that as his bone strengthener kicks in and the osteoclasts become inhibited, that the crosslink test will diminish back to normal range. So that's just to catch you all up. So anybody else have any experience with it?
Yeah, and just to follow up, Dr. John, I guess the normal range for males, 50 to 68, is 87 to 345. As I said, mine was 649. And for males over 68, they have not established the range yet. They don't have the data.
Yeah. You probably could roughly think of it as about 400. I don't know. If it doesn't go down, then you look for the reason why.
Thank you.
Anyone
That's all
else?
I have.
Okay. Mark, could you unmute and tell us what's up?
Well, I told you I wasn't sure if I wanted to bring this up or not, and I'll sure tell you what my dilemma is and then see if we should go forward or not, but it's about mortality. I'm one that I read all the literature that comes with all my medicines, and I just started, what did I start? Pluvicto last week, and I read all the literature that came with it, and it says without Pluvicto, the median survival is 11 months, and with Pluvicto, the median survival is 15 months, and I can't get that out of my head. And they don't tell you when you start to measure it, but it just, do I have 11 months? Do I have 15 months? I'm planning on well over a year, but
speaking for myself, and I think probably some of the other moderators, when we first heard those kind of numbers coming out, when Pluvicto was first appearing, we were sort of looking at each other and saying, what's the point of this? But when Pluvicto works, it's pretty good. It's pretty remarkable. And those studies were not really well standardized for genetic. If you look at the clinical and genetic and pathological predictors of Pluvicto response, back at that time they were very poorly known. Even now they're very poorly known. Even PSMA PET scans are kind of a somewhat crappy predictor of Pluvicto response. I don't know. I'd like to hear what some of the other guys think, but I think it's worth doing it, and you're not going to suffer. You're not going to suffer terribly just for the sake of living a few months longer. I don't think it's going to work that way. I don't think those numbers should concern you at all. Len, can you help us out here?
Well, Mark, when you read that Pluvicto extends overall survival by 4 months or 3 months, whatever it was, you have to keep in mind that's the median overall survival. So for 1/3 of patients who take Pluvicto, it doesn't work at all. So there's no overall survival gain. And for another third, it has a mediocre response, and the final third has a nice response. So you just have to hope you're in that top third, and it'll be a lot more than 4 months.
Yeah. We've all of us have seen these incredible scans where you have PSMA scans with mets all over the body, and then post Pluvicto, you don't hardly see any of them. We don't know what category you're going to be in. Let's get some more comments here because this is important. Jeff and Rick, Jeff and then Rick.
Well, I think Rick may cover the same thing as I do. People with BRCA2 have a better chance of getting success with Pluvicto, and those with PT10, what is it? Some 10 and RBC have a less good chance. So you want to get a somatic test, which can test your blood.
He's got it. He's got it.
Oh,
How recent
is it? I thought he said a tissue test. And how old is it? How old is the tissue that was tested?
Less than a year.
Okay. Let Rick go.
Rick. Muted, Rick. Muted.
And watch this carefully, Mr. V. How many of you right here are on abiraterone? On Abby? Only 2 today? That's it?
I have been, but not anymore.
I have been. Anybody know what the difference was from I'm trying to remember the original abiraterone trial. I can't remember the name of it. Anybody know what it showed up? What showed up? Jim Marshall knows. Go on, Jim. Tell him what the improvement was from the original abiraterone test.
Well, I don't know about the original one. At the time that I was told, it was ADT versus, I believe, it was ADT versus ADT plus, and with abiraterone, it was an increase of 17 months median survival time.
No.
Well, I'm already past.
No. Don't even go there. You can come back. The original abiraterone improvement was 3 months.
Oh.
That was from the trial that got the approval for abiraterone somewhere around 2012, I think. And I can't remember. It was 3 months. Now, why was it 3 months, Mark? Because when they give these drugs in the beginning, they tend to give them to people who are very, very sick. They always give them to people who are very close to end of life. And that never gets adjusted. Now, how do I know this? Because there was a doc who responded on one of these blog things. I don't know how the heck I got onto it, but he said he would never prescribe Pluvicto. He's a peer, and I think he's a GP, and he doesn't think that for 6 months it's worth it. Blah, 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 4 months. He doesn't understand trials. Basically, what they do in trials is they show long enough to get the FDA to approve it. That's what they do. How does that bear on reality? Not great. And if you think about the difference that Abby made, and how many people have been on Abby, and how many years people get out of Abby, that's where we are with the Pluvicto. So it's not always such a great idea to read through these. They have to put this stuff into the medical supplement, but it can make you crazy like it's making you. And yeah, you know what? You could get 3 or 4 months out of the Pluvicto, but you could also get 18 to 24. They don't tell you. What they don't tell you is how long it will work for. And what we have seen anecdotally is it probably only works for 18 to 24 months, and then you have to think about getting another dose or doing something else because they haven't done the tests on that. That would be a better thing for them to tell you. This is what you're going to get out of this drug. They always forget to mention that part. So, people go in thinking, oh, I'm going to get this radionuclide ligand and it's going to cure me. we see these fantastic changes in scans, and everything's gone. But what they don't show us is what that guy looked like 18 months later, and probably a bunch of the cancer had come back. So what I guess I'm saying to you is you got to be really, really, really careful. You got to be very, 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 very careful how you take those results. And if you would have called me, I would have gone through that with you.
Well, I'm not obsessing about this, Rick. I mean, when I first was diagnosed, it was 6 years ago with a Gleason 9, and I got a doctor to say, "I'm not sure you're going to make it a year." And so, I've gone through 6 years of not knowing, and I'm okay with that. And it just this reading all this literature just sort of brought this up. And maybe this is a discussion which is really more appropriate for men speaking freely, except this is pretty intertwined with the actual what I'm doing with the drugs and all. But I just find it really interesting. What do we think? What do we guys think when we look at? Well, none of us makes it out alive, but when you start putting an end time to it, how do we deal with it, and how do we feel about it? And I don't have any answers, but I want to talk about it.
Yeah, come to Men Speaking Freely. Right at the moment, I got 3 guys and 8 minutes.
John, we can go over. If you have to leave, I'll take it over. There's nobody has this room. Let's just keep exploring this up. But I understand if you have to leave, don't worry about it.
But it is important. It's a very important point. You're right, Rick.
I just want to. First of all, I just want to tell you, I'm pretty sure the original trial was the Cougar trial. I think that's what it was. I think that might have been the name of the manufacturer. I'm just trying to find it right now. And you can look it up. I'll find it, but you'll see that it was 3 months, which we would laugh at today if you'd said that's the difference that abiraterone makes. I do agree with Dr. John that we do talk about it in Men Speaking Freely, and you're always welcome to come back and come in and talk about it again. But I'm not sure I would be, me personally, but I'm not in that situation. I'm not sure I would be thinking that it made a difference of 4 months to me. I'd hope that it would give me, and we've seen it. We've seen some guys only get 3 or 4 months out of it and then continue. But we've seen other guys, and those are the guys, as Jeff Marchi correctly mentioned, who tend to have P10, RB1, and or TP53 or MBN. Just remind me, what mutations did you have in that last test, Mark?
P10.
P10?
Yeah. No BRCA.
No BRCA, but BRCA is actually good. ATM is good on this one, but P10, single P10 is okay. It's where we've seen the problem is where you've had 2 or more, like P10 and RB1 or P10 and TP53. It doesn't seem to have worked that well. Have you had any results yet since you started Pluvicto?
No, Dr. Agarwal wants to wait a few weeks before we do another PSMA.
Okay. Anybody else have any thoughts on this issue with relying on what trials tell you or what the FDA says in terms of overall survival or RPFS? Latitude, here it is, Latitude. That was the trial they approved it on. That was the one that said 3 months. Some of you, if you want to look it up, you can look it up. But it was the Latitude trial. Anyone else want to talk about that? How about you, Jack? You're usually good on this one. You're usually good on this type of subject.
You know, how to deal with death and dying, the inevitability that we all have to deal with when we never know and nobody knows and nobody can tell you, even though there are statistics out there that are telling you you may only live so long. There's no way you'll ever know. It's going to hit you one day and you're not even going to be prepared for it. And we never know when. It could be tonight. It's a situation that's like almost impossible to deal with because it's one of those things that we never know about. I'm watching a thing called The Pit right now. By the way, it's a fabulous thing. It's on the emergency room. It reminds me of when I was doing that kind of work. Oh, boy, I don't know how those people do that. Dealing with it every moment of the day. It's called The Pit on HBO Max. I highly recommend it. It's dealing with death moment to moment. Yeah, that's all I have to say.
Dennis.
Yes, I forget where I heard it or read it, but there's a saying about treating, high-risk prostate cancer, metastatic, and so on. The goal is basically to keep you alive long enough so that you will die from something else.
That's right. That's right. That's exactly the name of the game. You know, it keeps you going until we have the next best thing. And as Dr. John will tell you, there were plenty of next best things that at GU ASCO, right, Dr. John?
Yep, there were. Yep.
So, it's there you go. There you go.
I think I'll go on then, guys. I've got Scott next, who is back after, I don't know, 9 months or something like that for a quick catch up.
Yeah. I just wanted to say thank you for having me again. Thanks for allowing me to come back. I was diagnosed at the age of 53 with stage 4. It's kind of gone throughout my body, lots of mets. I'm just living life. I went back to teaching, which is why I couldn't join most of these because I was just not home. Because of the ADT, I got really, really tired, had a really hard time working a job full time. So officially retired after 30 years of teaching. I'm going in tomorrow into Salt Lake to see my GU doctor. I'm going to get my scan, see how everything looks. And that's really kind of just the update. My PSA has been undetectable for about a year, pretty much since I started ADT.
Ever since we met you. Good.
Yeah.
So the treatment that you've been doing, I'm just looking at my notes here since the end of 23, was Eligard and apalutamide, is that right?
Correct, yeah.
And you had how many you had 20 spots, but that's right. But you had 20 spots, but he didn't do chemo. Why was that? Do you know?
I've asked multiple times about doing chemo, and he said just because of my age and because how well my body has been responding to the ADT, he's holding that one back. Because I asked him about doing the triple therapy, and he said, "I'm not quite there yet. I don't think we're ready to go there yet."
Okay. Well, you might just. I mean, obviously, you've done real well. You're undetectable. You're still on the same treatment, right? Still
Correct.
on the ends, so you're undetectable. You know, the options are to well, I'm thinking you've been on about 18 months. Is that right? How long?
No, probably about
15?
no less than about a
Less than
year,
a year.
roughly 12 months.
Okay. So probably he's just going to tell you to stay the course, and that's what we would say: stay the course. And
That's
you
my
know,
guess.
and I think if it were me, I'd be wanting to do another PSMA scan to see what's changed. And
I
I
am
would.
getting. So I think tomorrow I'm getting a CT scan and something else. I don't remember what it is.
Okay, well, I think I think that, you know, a PSMA scan would be a great idea. Did you get a PSMA scan originally when they saw those 20 spots? I don't
I
know.
did, yeah. I believe I was just trying to go through and see what all my scans were. I had, let me look here. I think I had I know I had a PSMA. I had multiple CT scans.
Okay.
Um,
So, you know, I think then you could do a comparison. You can reasonably ask him to do another PSMA scan. And maybe they'll just do it tomorrow. Maybe that's one of the scans they're going to do tomorrow. But I think that's what we'd like to know. And I think you just got to stay the course. And if you, I mean, the standard of care, and Dr. Agarwal knows this better than anybody. This is Dr. Niraj Agarwal, not Dr. Rahul Agarwal. This is Dr. Niraj Agarwal at Huntsman. But he knows it better than anybody, is that normally if you've got more than 4 or 5 spots, you do chemo. So, but you know, if he wanted to keep it in his back pocket and he thought you'd do well and he played that hunch, he did you a great favor and you did do it well. The question is, you know, is it prophylactic? Do you want to use it or you don't want to use it? But
yeah,
he's doing well by you, Scott. Now that you're retired, we also want to see you on the under 60s group, man. You can come to that.
I'll be there.
You get that reminder, don't you?
I do. I've just started looking up my emails again. That's how I remembered I needed to come to this one tonight.
Yeah, well, come to that under 60s because we've got some really good guys. None of them are on here tonight, but oftentimes they are here. But we have some really good guys in that under 60, and I'm sure they'd love to talk with you.
Okay. I'll be there.
Good. Anyone else want to say anything to Scott about what he should talk to his doctor about tomorrow? Anybody got any other ideas for him to bring up?
I just have a quick question that I'll kind of pose to the group, and then I'll shut up.
Please.
But everything that I've been understanding is if my PSMA or PSA has been undetectable for roughly a year, when I go back, I've been on the ADT, I think since February. When I go back, if I get another PSMA PET scan, which I just got done paying off my last one, if I get another one, is it going to show anything new? It really should just show pretty much the exact same thing that I had before. Am I correct in that assumption?
Well, we'd hope it shows a lot less than you had before. That's what we'd hope. We don't want to see the same. What we want to see is that all of those metastases have gone away. That's what we're looking for. I'm puzzled why it's costing you so much for this PSMA scan. Is your insurance not covering it?
I think and again, this was about a year ago, so I don't remember what all it entailed, but I think it was, I'm going to make up some numbers. I want to say it was like $75,000. My insurance paid 35 or whatever it was. I had to pay $5,000 out of pocket, and then I met my deductible. So then since then everything's been free.
No, there's
Well,
something wrong there. The PSMA scan should not cost more than about $3,500 in total.
oh,
So I don't know what's going on, and you need to follow that through with Huntsman and find out what the heck's going on, because they may owe you some money. Even the retail price on whether they used Locomets, Pylarify, Illuccix, the other one, Paloma, whatever they call it, they're all now in the region of $3,000 to $4,000 retail, and
okay.
you can get subsidized. So something isn't right there, Scott.
So is that the same? The PSMA, is that a PSMA PET scan? Is that what we're
Yes.
talking about?
Yes.
Okay.
Yes.
I'll look
Now,
into that a little bit more.
if you're talking about a Pluvicto treatment, which is using PSMA for curative, then the retail price on that is a lot more. Then you're talking the sort of numbers that you're talking about. Well, not that high, but it's a lot more. But a regular PSMA scan from any of the providers should not be more than $3,500. So something's wrong, and somebody might, if that's what they're charging you, you're getting taken for a ride. Let us know, and also let us know who it was, because we know the providers. We know Lantheus, we know Blue Earth, we know Telix, we know all these people. We can go to them and say, what the heck's going on? Can you dig into this and find out, please?
Okay. I will look a little more into that one.
Steve, sorry for you waiting so long. You have something to bring up?
Well, yes, a quick question. I guess I'm not expecting an answer, but what's impacting my life most now is a shortness of breath. And I see that one of the side effects of Lupron is a shortness of breath. There's multiple things that could be causing it for me, but I was just wondering if anybody has experienced shortness of breath while on Lupron, and if it occurred early on in the use or later.
Are you on
Does it occur?
Flomax? Are you on Flomax, Steve?
No,
Have you ever been on Flomax? Have you been on
no.
Flomax recently? Okay.
Is this shortness of breath on exertion, like walking upstairs, or at rest?
On minor exertion, pretty modest and not all the time there.
Are you on doublet therapy or just ADT by itself?
I'm on Lupron and abiraterone, with the abiraterone paired with dexamethasone.
You're not anemic?
No.
Your hematocrit and hemoglobin are all perfect?
The only thing I've had lately is I've had on my blood tests, they haven't been able to give me a platelet number because of platelet clumping.
That's probably
But the other
unrelated.
numbers are all in range.
Marshall?
Steve, have you thought about a stress test? And I had the same thing. I thought it was, ADT and all that stuff. Turned out to be heart problem. Bypass eventually.
Yeah, I had a bypass about 4 years ago now. So, and that seems to all be good. I am on a
blood thinner.
A high blood pressure med that that limits the pulse. Also, a
metropole tartrate.
Yeah.
Beta blocker.
Beta blocker, correct. So it could be due to the beta blocker. Supposedly, my blood clots have cleared in my lungs, So, and this shortness of breath has actually gotten worse as my blood clots cleared. So it seems very odd.
Are you taking prednisone, Steve?
No, I'm taking dexamethasone. I was changed from prednisone to dexamethasone about a year ago.
This prednisone can also cause a shortness of breath.
I think that Jim is right. That as we hate to say it, but sort of shriveled up as time went by on our ADT. Our muscles got weaker, our endurance got less. I mean, I started noticing shortness of breath, times that I would never have had shortness of breath before, climbing stairs. Hematocrit goes down a little bit. But the burden of proof is to prove that it has nothing to do with your heart. Once you do that, then you can attribute it to less serious and potentially reversible causes. Go see a pulmonologist, keep
Okay.
on exercising, but you have to just make sure that your bypasses are not starting to clog up. Even though you're not having chest pain,
Right.
I think it would be a great time to report to your cardiologist, revise your blood pressure medicines if necessary, and make sure that your cardiac circulation is fine.
So let me suggest this. What I would do is I'd look for a cardio-oncologist. Is that what they call them, or an oncocardiologist? Is it an oncocardiologist or a
cardio-oncologist? I think it's a cardio-oncologist.
I think it's a cardio-oncologist, and there just happens to be one at UW, because I'm looking that up as we go, and she has a name like Dr. E. We may have to call her Dr. E2. We've been talking about E2 tonight, so we can talk about
yeah.
Her name is Effie Andrikopoulou. Effie Andrikopoulou, and she seems to have a very nice 4-minute video, which obviously I can't look at right now, on Facebook. So you can check that out and see if you like her. And let me see if I can find her. But these docs, and this is becoming a more and more accepted subspecialty. They know what the cancer drugs are doing to you, and so they are going to be more alert to, could it be the prednisone? Could it be the Lupron? I'm about to give you Efstathia. Oh, that's interesting. Effie is short for Efstathia. That's the same name as Efstathiou. So
boy.
maybe she's a sister in spirit to Dr. E. I can ask Dr. E if she knows her. Here's the link. There you go. Don't say we don't give service with a smile. And maybe talk to Yazevsky. Any joy in moving to Dr. Fong?
Dr. Fong responded to me immediately.
Yes.
And I told him in my first email, I told him that I was at Fred Hutch, but didn't give him Yazevsky's name. So he just asked who I was being treated with by now. So, yeah, now I'm waiting. And so I told him, and now I'm just waiting for further response, I guess, sounds like he may be talking to Yevzevsky.
Did you tell him you were an AnCaner?
Yes.
Okay. Well, you know, I love Larry. He's a wonderful doc. He's a wonderful doc. He doesn't do a lot of clinical practice, but anybody who has him as a clinician are very, very, very lucky. He's the best. And it still reminds me that I've got to drop him an email, which I know I have to do. But I would ask whoever is your quarterback right now that you tell them you'd like, especially since you have a stent and that you would like an appointment with this cardio-oncologist. I think that's what they're calling it, because they call it cardio-oncology is the name of the area she's in.
Yes.
And I would start there. Because I'm also concerned that they haven't been following you close enough. The cardiologist may not have been following you close enough whilst you've been on this treatment. You know, maybe there's something up with your heart, and maybe you do need, you know, maybe the stent needs some repair or something like that. And I think probably it's not a bad idea to get it run down. What do you think, Dr. John? You're very good on these cardiology things.
Absolutely. I think that should be ruled out. Len, you had something?
Yeah, basically, I was just going to suggest he follow your advice, Dr. John. You know, get screened for any cardiology problems. And if they're all negative, as they were in my case, you'll come back with the diagnosis of deconditioning. And so in your case, between the hormonal drugs and the beta blocker, you're probably not exercising very much. You're probably tired all the time. And that's, you know, you're simply deconditioned. That's the shortness of breath. You try and exert yourself and you can't breathe.
Yeah, I can now do about, if I'm on the flat, I can do about 2 miles at a little over a 3-minute pace, 3 miles per hour pace, 3 miles per hour pace.
I was going to say that's Olympic, better than Olympics.
Yeah, no, 3, yeah.
We understand.
Okay. But yeah, any hills take it out of me. And
yeah.
Okay.
I can't go up hills. The only other guy I have on my list has left. So we're done.
We are.
Oh no, John. There you are, John. I thought you had disappeared. Thank you very much.
I did disappear and I came back.
Oh, okay.
So I'll be very brief. I got diagnosed Gleason 8 end of December. I got a PSMA PET scan. It's all in the prostate. My treatment plan is Orgovyx, then a brachytherapy, then I'm going to get radiation. So I'm one of the guys on here that didn't get his prostate taken out yet. And so I just wanted to know, how long am I going to be on Orgovyx? By the way, I've been on Orgovyx a week and I feel nothing. And so how long do I have to be on Orgovyx before it kicks my butt? And how long do I have to be on Orgovyx till I hit castration level? PSA.
You have to be on Orgovyx for a shorter time than Lupron for those things to happen, but they won't absolutely necessarily happen. Some people tolerate those drugs very, very well and better than the Lupron type of drugs. Your testosterone level is dropping rapidly now, and so you will probably start experiencing some symptoms within the next very few weeks, I would think. Hot flashes, things like that. If they happen, like I say, it's not 100%. As far as kicking your butt, I have never been on Orgovyx. Maybe somebody who has can speak, but the symptoms of castration seem to be long and cumulative. So you might have a little bit faster ramp up than people on Lupron, but it won't be all of a sudden it kicks your butt. It probably will be gradually ramping up.
Okay.
Who has started on Orgovyx from scratch and can describe this? Well, we don't happen to have anybody right now, but we usually do.
I'm noticing very few people start with Orgovyx because everybody's on Lupron, and I don't know why.
Well, it's cheaper and it's more common, and urologists tend to reach for it. And many people actually get on it later on during a switch. But there's no reason why it can't be your initial drug if you can afford it and your insurance will pay for it.
Okay.
Agreed, Len and Rick?
Yeah, it's the best drug to start with if you can do it. Much better than starting on Lupron. So you're way better off. A couple of things I'd say, and then I see that Joel has his hand up. So how long before it'll affect you? Like we say, it's going to be different with these different drugs. It's going to be shorter. The Orgovyx should drop your testosterone more quickly, which means you should feel the effects of having no testosterone more quickly. But everybody experiences that differently, so we can't tell you. But it probably is going to be around 4 to 8 weeks that you'll really start to notice it. It's not unusual that you don't notice it in the first week. How long before you become castrate resistant? I would say you don't even need to think about that. That shouldn't even be a concern of yours at this point in time. It could be years. You may never become castrate resistant because you may never need that much treatment. We don't know, but this initial phase of your treatment, they're probably going to keep you on. How long have they suggested that you have to take this for? 2 years?
They've said 2 years, but I'm getting the impression that if I get the brachytherapy and then I get radiation, brachytherapy is going to be in about 2 months from now. We're going to do brachy. Then we're going to follow the brachytherapy with radiation. And so they've got me on 2 years. I can't imagine after I've been on this for 12 months, plus I had brachy, plus I had radiation. Why would I stay longer on it, right?
Well,
they may cut you down to 18 months.
Hold on, Dr. John. Hold on, Dr. John. We'll come to you. Are you the doc, or are you willing to take the advice of the docs?
I'm not going to jump on that question. I'll take the advice of the doctor.
Okay, and if the doctors are telling you that it's probably going to be 2 years, there's a reason, because they've done the trials. Okay. Now, the shortest time you should be on is 18 months from per the trials. The longest time is probably 3 years. We seem to think that 2 years works. Some people get off early, like Jimmy. Jimmy's not on tonight, but Jimmy got off after 15 months. If it were me, I wouldn't have gotten off. I got off after 28 months, which was what was recommended to me. We don't know, but I would not be going into this thinking, well, I can't see why I need to be on for more than 12 months. When we've seen people come off these treatments earlier, we've seen relapses. Okay. Some of them serious relapses. So I just sort of want to take out the big stick and say, listen to what the docs tell you. Don't even start talking about coming off until at least 18 months. And then at least you've got a place to negotiate from. Dr. John and then Joel.
I was going to say basically the same thing. They may ease you back to 18 months, but I wouldn't go any earlier than that either. Joel?
Yes, Dr. John. I was never on Lupron. I was only on Orgovyx for 24 months. I came off last October. As far as side effects, never had any. So I may not be a good candidate for the question, but I never had any symptoms while I was on. I never got any symptoms when I went off of it 24 months later. So to me, Orgovyx was almost a non-drug. But it took 5 months for my PSA to go down to less than 0.04, and it's been that ever since it went to that reading 5 months after I started taking it.
So, General, two questions. What was your baseline testosterone? And what's your testosterone now? And what's your testosterone been doing during all of this?
Okay, I started, my baseline was 325, went down to less than 5 for most of my treatment for 24 months. Sometimes the reading was less than 10. But since then, since coming off of last October, went up to 14, went up to 24, but it has not. I did take a testosterone test last Friday, but I don't have the results yet. I should get the results within a day or so, but Dr. E doesn't believe my testosterone will ever recover because of my age. So I'm not expecting it to recover.
Yeah. Now, the reason you may not have had any effect on you could have been Dr. E, of course, because she's a miracle worker. We know that. So, if that's why we send people down to her. I think she winked at me when I said that this lady's name was Efstathia. I have a feeling she might have just given me a quick wink from behind your shoulder, but I'm not sure. Yeah, I mean, John, what you're hearing is that people are so different, and we don't know how you're going to respond, But I can tell you that we know all the tricks of the trade to help you if you do have symptoms. And if you keep coming back, we've got your back. We'll keep helping you with those symptoms as you respond. You might get lucky like General Joel, but you might be like some of the other guys who are crippled by hot flashes or the fatigue or the pain or what have you.
Okay, so I'm in it for the long haul.
Yes.
For the long haul, and I'm going to follow my doctor's advice.
Yes.
We're just going to kick its butt. Okay?
That I agree with. And when 18 months comes up, which will be roughly about May of 27, something like that, we'll be talking to you about whether it's a good idea to go back to the GU MedOnc and have a chat with him.
Okay. All right. Very good. That's why I come here, just for this. It was worth everything. Thank you very much. Appreciate it. Totally. Great group. Thank you.
Thank you, everybody, for coming. We'll see you next week.
Good night, everybody. Oh, the general, we've got not quite as high because I'm not good. Hank, how do ranks compare? Where does general, that would be an admiral in your books, wouldn't it?
That's right.
Vice admiral. Joel is as vice as they get.
Vice admiral. Okay. I never figured out where commander fits in. I don't know where that fits in.
Lieutenant colonel.
Yeah, that's just the lieutenant colonel.
Okay. All right. Okay.
Joel says jump and I say aye, sir.
Hey, everybody.
Okay. Well, we want all you guys to come into this new Vets Speaking Freely group because it's going to be, I'm really looking forward to that. So, watch out for it. All right. Goodbye, everybody.